Hello, med students. Are you trying to improve your score? Well, you came to the right place. Here I'm going over every single high-yield topic that you need to know by the time you've finished MBME 29 in your prep. We finished the first 50. These videos take dozens of hours, so please be sure to like and also subscribe if you find it helpful. My goal is to help you pass step 1. All these questions are original. Here we have a 25-year-old woman delivering a term male infant. She reports self-limiting illness with fever, rash, joint pains. Okay, so the mama is sick, and she does not get medication. And then the newborn has a murmur. Oh no. Bilateral white pupillary reflexes. Okay, some vision problems, and also failed auditory. Okay, so vision, hearing, that is a triad for rubella. It's cataracts, sensory neural deafness, and also a heart defect. In this case, it looks like it's a patent ductus arteriosus. So basically in this question, we got a mom who's got a mild illness like a fever, rash, and post-auricular lymphadenopathy. Auricular, by the way, just means like the ear, so posterior to the ear, lymphadenopathy, and it's going to clear, but then the fetus is going to be in trouble because now the kid's going to have maybe like a blueberry muffin lesion with extramedullary hematopoiesis in the skin. And there's actually a vaccine for this. It's the MMR vaccine. It's a live attenuated vaccine. And you just have to notice that triad of the cataracts, the hearing loss, and also the heart defects, and that's rubella, especially if it's like a torch infection. You might be saying, okay, cool beans. What's a torch infection? Well, that would be like toxo. Other is like syphilis, rubella, which is the answer to this question. C stands for CMV, cytomegalovirus, and then H stands for HSV. And they present differently, but toxo, you need to know it's like raw meats and then cat feces. And the big one for rubella is cataracts, PDA, blueberry muffin rash, and they usually have an MMR that's not given, like a vaccine that's not given, and it should be before pregnancy. And I figured these are kind of difficult sometimes, so I wanted to cover them. Like CMV, that's transplacental vaginal. It could be like mild or mono-like maternal symptoms. Now in CMV, you can also have chorioretinitis. That's a big old fancy word for saying that you got inflammation of the chorioid and the retina of the eye. It's part of the uveal tract. You can also be seen with the blueberry muffin rash for this one too, and it's the most common congenital viral infection. Now, what's interesting about HSV as one of the torch infections is that actually occurs during pregnancy, and you'll get painful genital vesicles. There's usually a vesicular rash and encephalitis that's seen. So looking at our answer choices, a vesicular rash is zoster or HSV, would be CMV, and anemia with target cells, that's a thalassemia, so liver problems. But yeah, now you know torch, the congenital infections that cross the placenta and affect the fetal development. But some other ones that are important like HIV, that can be vertically transmitted, but it causes immunodeficiency, usually not congenital malformations in HIV. HTLV, which is the one right here. This is a retrovirus that causes adult T-cell leukemia. That can cause limb hypoplasia, cutaneous scarring, but this is not common unless you have an early pregnancy. But these guys here on the right, these guys are your torch pathogens like CMV. This is sensory neural hearing loss, periventricular calcifications, microcephaly, blueberry stuff. Herpes. So herpes that's acquired during delivery. You should think of a C-section if there's active lesions. But yeah, this causes vesicular lesions, seizures, encephalitis. Rubella was the answer to this. Cataracts, deafness, PDA. Toxos, raw meat, cat feces, hydrocephalus, chorioretinitis, and intracranial calcifications would be seen with toxo. And syphilis goes with that saddle nose right there. That's the other, right? So that's the snuffles, desquamating, rash, like when the skin starts to just come off in scales. Also Hutchinson's teeth. Saber shin, saddle nose. All right, so hopefully that's a good little recap on all this stuff. These next two questions we're going to fly through pretty quickly. One is uncomplicated grief. And I think the most important thing that you should do on STEP is distinguish this from depression. So uncomplicated grief can take many forms, but it's never going to have 5 of the SIGECAPS. So 5 of 8 for 2 weeks would be medical depression. But here we're not having medical depression, it's just uncomplicated grief. Medical depression is a bit more interesting on the exam. You have sleep changes, loss in interest, guilt, energy loss, concentration, difficulties, appetite, psychomotor, and these ideations. The sleep comes from the serotonin, interest loss is from the dopamine. The guilt is a prefrontal cortex dysfunction. Energy loss, HPA axis, and also females are twice as likely, and so there's a hormonal influence as well. Cortisol is a known instigator. There's something called the stress diathesis model, although people are thinking that electrical circuits and voltage has a lot to do with it these days, but they're not going to really test you on that. But yeah, cortisol might disrupt the HPA axis, causing dysregulation of dopamine and serotonin, which can cause mood disorder. But the stress diathesis model says maybe there are instigating stress factors which can cause medical depression, but that's 2 weeks, 5 out of 8 of the SIGECAPS, and it's different than uncomplicated grief, which can take many forms. Okay, that's all I wanted to say for that one. I think if you know the difference between uncomplicated grief and depression, then you're going to be good to go. And so that's going to cover that topic for MBME 29. Now for 53, I want to talk about colon malignancies. Now on step 2, especially less on step 1, but still may be seen, you have right-sided or proximal colon problems, and then you have the left-sided, which are more distal. The right-sided is typically seen with iron deficiencies, like iron deficiency anemia, fatigue, weight loss, all that stuff. Left side is usually bowel habit changes like obstruction, blood streak stools, things like that. On this right side, it's going to be more of a silent bleeder. And by the way, the reason I'm drawing it right and left is because when you're practicing to become a physician, we always want to imagine that we have a person there, right? So this is their right side of their body, this is the left side. So just getting in a habit of that. When you're reading x-rays, you always got to flip it. So silent bleeding versus the apple core would be seen on the left side. Right side is a little bit more likely to be involved in Lynch syndrome. So I'd think of that for step one. Whereas the right side, more FAP, more sporadic. But it's also important to distinguish between a lot of these cancer kind of instigating syndromes like FAP, familial adenomatous polyposis, Lynch syndrome, Peutz-Jeghers syndrome. And with FAP, there is a 100% risk of colonic cancer. And the key word you should think about Lynch is microsatellite instability. There it is. And you can have right-sided cancers, endometrial ovarian risk. Marilyn Lynch, the CEO, right? Cervical endometrial ovarian risk. Peutz-Jeghers, that has the weird mutation associated with it, the STK11. It's also autosomal dominant. They all are. The hamartoma is a non-cancerous or benign growth that's made up of like an abnormal mixture of cells and tissues that are normally found in that area that it occurs. It's not cancerous, and typically you find it incidentally. And this can happen in various parts of the body, but the lungs are typically where we note it. And here with Peutz-Jeghers, you can also have mucocutaneous pigmentation, so on the lip, like the lips, the oral mucosa, stuff like that. There's a risk of GI and pancreatic and breast cancers as well. But yeah, apple core on the left side, iron deficiency on the right side. Bowel changes would be a little bit more left-sided, so like the pencil thin stools, constipation, that stuff. Microsatellite instability is the hallmark of Lynch syndrome. And then you should know for FAP, the APC gene, it's like uphold carrot. This is how I'd like to think of that. Lynch has the MLH1 microsatellite instabilities. Peutz-Jeghers is the STK11 mutations. So if you're feeling good about that, let's do practice question. We have a 61-year-old man comes to the clinic with fatigue and shortness of breath on exertion. He has no history of GI bleeding, but routine labs reveal a hemoglobin level of 9.5. Colonoscopy reveals a mass in the ascending colon. Biopsy shows a moderately differentiated adenocarcinoma. Which of the following is the most likely underlying mechanism in this patient? Okay, the answer is going to be there's a DNA mismatch repair problem, Lynch syndrome, aflatoxin, you think aspergillus, hepatocellular carcinoma, hepatitis B, also carcinoma there, HPV would be E6, E7 associations, and estrogen, breast cancer patho. So yeah, many causes of colon cancer develop without any symptoms at all. And so if you see a new iron deficiency, like in this patient, and it's going to be like an older man, maybe like a postmenopausal woman, then maybe you should think of colon cancer until you're proven otherwise. And there are two major pathways that drive this. There's the adenocarcinoma sequence that involves APC, CRAS, P53, right? APC, then CRAS mutation, then loss of P53. That's the adenoma carcinoma sequence. And then there's the microsatellite instability. That is the MSI pathway. And in the MSI pathway, that's the mismatch repair problem with Lynch syndrome. And right-sided tends to bleed, while the left-sided tends to obstruct. So here we had a right-sided mass, so it's probably going to be an MSI pathway stuff, so it's a mismatch repair gene problem. All right, the next topic is anytime you have a mean, median, and a mode question, you should just be super thorough. They might ask you, hey, what would change if we have like a 0.5, 0.5, and 0.6, and we change this 0.5 to a 0.6? Well, then it'd be 2 0.6s, and so the mode would change, and also the median and the mean would both rise. Right? So just be super thorough. They're super easy questions. Don't miss those points. That's all I need to say for that question 54. Okay, for next question, we have a 17-year-old girl who is evaluated for prolonged menstrual periods and easy bruising. She reports frequent nosebleeds in childhood and gum bleeding during dental cleanings. So we're already thinking of von Willebrand's, which of the following is the primary defect. It's the decreased platelet binding to the subendothelial collagen. Impaired platelet adhesion is what you should think of. And von Willebrand factor normally tethers these platelets to the subendothelial collagen of the GP1B. The 2B3A is Glanzmann's, and Glanzmann's is a big old name, and so it has more numbers. Whereas like Bernard Solier, BS, there's only one B in that. So BS, Bernard. And so I like to think of that's GP1B. I wonder if that's an answer choice. No, it's not, but you get the idea. Glanzmann's super long name, so it has a super long GP2B3A, and that's all you really need to know. It's the aggregation problem though, not adhesion. Aggregation feels like it has more numbers associated than adhesion does, and that's why I think of it as 2B3A as opposed to just the one. Autoantibodies, ITP, thrombopoietin, a megakaryocytic thrombocytopenia, that's a low platelet count, and vitamin K would be 27910. And so you have a normal platelet count there. It's just that there's increased bleeding time because the platelets are there, they just can't stick. You also have mucocutaneous bleeding, so nosebleeds, menorrhagia, gum bleeding. You have increased PTT because von Willebrand carries and stabilizes the factor 8. And ristocetin tests are abnormal. That means it's defective. Bernard-Cillier, the giant. And I wanted to throw celiac as well. That's just infections in albino. It's kind of unrelated, but sometimes people mistake that because it also has the giant stuff, but this is a different type of giant. And Glanzmann's, of course, we mentioned that's when you have no aggregation, whereas these guys are no adhesions. All right, for the next question. Here we have a 67-year-old man presenting with fatigue, generalized bone pain. He's lost 8 pounds unintentionally. So maybe some type of cancer. Oh, we got renal issues as well. Hypercalc. I think this is multiple myeloma. And so the answer is going to be D, osteoclastic activation by tumor cytokines. And D, this is multiple myeloma, which does not have PTHRP, that's squamous cell stuff. Vitamin D analogs, granulomatous disease, sarcoid stuff. Parathyroid would not have light chains. GI calcium absorption is vitamin D excess. These Bence-Jones are the light chains. You see bone pain in multiple myeloma and Rouleau formation. There's the crab. Calcemia, renal anemia, bone lesion. This one's super pathognomonic, but you could see the macrophage infiltration stuff. So IL-1 is elevated, TNF-alpha, MIP-1. These are all kind of big giveaways for the mechanism of action for multiple myeloma. Also the RANK-L, so through the activation of NF-kappa B, you cause an increase of the osteoclast, causing these lytic bone lesions, which is indicative of multiple myeloma. Okay, so that's how you think and diagnose multiple myeloma on test A for step 1. You might see like IL-1, TNF-alpha factors, that stuff. Okay, in our next question, we have a 31-year-old woman presenting with intense vulvar itching, burning, and thick white vaginal discharge. She recently completed a course in clindamycin for dental abscess. Pelvic exam shows erythema of the vulva and clumpy white discharge. This is Candida vulvovaginitis. 4.3 is the pH, and first line is fluconazole, which causes the inhibition of ergosterol synthesis via cytochrome P450 inhibition. All right, there are a couple of antifungals and things we got to know. So azoles, that causes the inhibition of ergosterol synthesis, so no ergosterol there. Polyenes like that, those will bind the ergosterol and cause the pore formation. There you should think of amphostatin. Echinocandins, these guys are big players. They inhibit the beta-glucan synthesis, and so it will just cause no cell wall to exist. So if a lot of the azoles and the polyenes like nystatin and stuff, they aren't working, then maybe consider this drug so you can just literally wipe out the cell wall. The stopping of the DNA and the RNA is the job of fluticasine. If you give them terbinafine, then it causes a buildup of squalene, which is toxic. That's used for tinea infection. So antifungal mechanisms like azoles are used for vulvovaginal candidiasis. And you know it was candidiasis because of that thick white cottage cheese stuff. Also the pseudohyphae on the KOH prep tells you it's diagnostic under the microscope. And the pH that is low, like 4.5 or less, will distinguish it from the mus or bacterial vaginosis. And then the recent antibiotics or contraceptive use, those are common triggers here. And so you use an azole antifungal that targets ergosterol synthesis through the CYP450 inhibition. You might also have some interesting associations and risk factors, like one of them is actually diabetes, or immunosuppression, right? It'll impair your host defenses. Pregnancy is one because you have hormonal changes. Fluconazole, miconazole, those guys inhibit the 14-alpha demethylase, which is a CYP450 enzyme. Ergosterol is the fungal cell membrane component. It's like kind of like cholesterol in humans. This is a good way to think about it. And so Candida normally colonizes the vagina as part of the flora, and the antibiotics and the hormonal changes decrease the lactobacilli that increases the Candida overgrowth. And so then Candida starts to make those pseudohyphae in the tissue, and azoles like fluconazole inhibit the CYP450 dependent demethylase, and that causes decreased ergosterol synthesis and also membrane dysfunction. And so it's a fungostatic effect, right? The yeast just can't grow. They can't replicate. It's amazing. And usually on the KOH prep, you'll see the budding yeast and pseudohyphae. So yep, give them fluconazole and know that it inhibits the demethylation through the CYP450. So yes, it's the fungus among us, kind of like the Pokemon. But yep, your azoles, they target the fungal CYP450, 14-alpha demethylase. Resistance can happen through efflux pumps. CYP450 is partially affected, so it can interact with warfarin and phenytoin and those 450 susceptible medications. Penetrates the CNS, used it in crypto, Candida, coccidio. Itraconazole is used in histo. Here's another practice question. Start on medication. How does it work? Blocks linosterol 14-alpha demethylase. Membrane pores is amphocytarin B or nystatin, which there they are on this nice sheet here. Glucan synthase is the echinocandins that stop the cell wall. Thymidylate synthase, the 5-FU. Flucytosine stops nucleic acid synthesis, and squalene epoxidation. Terbinafine inhibits squalene epoxidase, so causes the squalene growth. Kills your tinea. For the next question, you might see somebody with, I've seen a lot of questions on this on different MBMEs. Blisters. How do the blisters happen? So the pathophys of the blisters is you get mechanical, autoimmune, thermal, infectious injury. You lose the desmosome integrity. Now you get the subepidermal, like in Bullous, Pemphigoid, seen in frictions and burns. Here's a practice question. 76-year-old man, large tense blisters. Nikolsky sign is negative. Autoantibodies against the hemidesmosomal proteins. Bullous, Pemphigoid. Negative Nikolsky. Positive would have been the shearing on the rubbing, which is Pemphigus vulgaris, not Bullous. So yeah, those hemidesmosomes, they are super important. They anchor the keratinocytes to the basement membrane. That's just like the cells that produce keratin. The key features are linear IgG and C3. Here's another practice question. 74-year-old woman, several large, tense blisters on her trunk. She's got linear deposition of IgG. What's going on? Dysfunction of the anchors to the basal cell to the basement membrane. Bullous pemphigoid. It's when you attack the hemidesmosomes. Think of the H attaching, attach it to the basement membrane. Now, the linkage itself, the desmosomes are attacked to Pemphigus vulgaris. Neutrophil migration, selectins and integrins, T cell homing, CLA, and tight junctions would be in the intestinal and the renal epithelium. So, seen in elderly, itching, that kind of stuff. Blistering. All right, this one's really interesting. Here we have a 32-year-old man presenting with rapidly enlarging thigh mass. Biopsy has a pleomorphic polydifferentiated cell with scant cytoplasm and hyperchromatic nuclei. We have strong positivity for Desmond. All right, so Desmond, what is that? Muscle. Anytime I say the word muscle, I got to do some exercises. So yeah, it's smooth muscle, right? Desmond is a muscle-specific intermediate. And here you really have to know your tissue markers, right? So on muscle tumors, you have Desmond. And I did this beforehand, right? Those guys are the intermediate filaments in the muscle cells. And they're positive in like rhabdomyolysis or leiomyosarcomas, anything with a myo in it, right? Myo, Desmond. The cytokeratin is in the epithelial cells. That's positive in carcinomas, right? The skin, the glands. For the nerves, you should think of the central, the peripheral, neuronal support, glial cells. And the marker there that you should probably know is GFAP. And GFAP is an astrocyte marker. So glioblastomas, ependymomas. And the last one I think I'll just add for completion is S100. That's for melanocytes like melanomas, Langerhans cells, schwannomas. So they could ask you this in a number of ways. They could say, we got like a 6-year-old boy. He's got a big old mass and it's spindle-shaped tumor. It's got cross striations and it's positive for myogenin and Desmond. And then they'll say, hey, what's the diagnosis? And you're going to say it's a rhabdomyosarcoma or something like that with a myo in it because of the Desmond. Cool beans. All right, for this next question, I think it's important to know just what is peritonitis? Like what even is it? Well, I guess if you break apart the word, you know, it's peritonitis is an inflammation itis of the peritoneal lining of the abdominal cavity. And you're going to see just like acute, painful, and life-threatening presentations. Now, it can be primary, it can be secondary. So primary is like cirrhosis or like a nephrotic syndrome. And secondary would be like a perforation or a GI tract thing. Maybe you have a peptic ulcer that ruptures, or you have appendicitis, diverticulitis, some sort of a trauma. Or you could even have a tertiary peritonitis. And that's after you give treatment. So there's postoperative or immunocompromised patients who will suffer from this. And the big thing here is the rebound tenderness. So if you lift the hand, oh, that's more pain than it was when you were pressing down, right? That is rebound tenderness. Guarding and rigidity, that's the involuntary muscle tightening. Ooh. There's also a board-like abdomen that people describe. It's classic for the surgical abdomen. And you'll have absent bowel sounds. So it's a paralytic ileus. You could also have diffuse abdominal pain, fever, tachycardia. The way to think about this on boards questions is, okay, there's going to be like a trigger. Maybe there's a GI perforation. Maybe there's a bacterial infection. Maybe there's a leak of the bile. Who knows? There's irritant in the peritoneal cavity, right? There's bacteria, there's acid, there's feces. Who knows what? Maybe somebody had their stomach cut open and cat feces got inside. I don't know. A million things, right? Massive inflammatory response. And then you get exudate and neutrophils that flood the cavity. Okay, what is exudate? Well, that's any mass of cells or fluid that has seeped out of the blood vessels, especially in inflammation. That's what exudate means. So you have that and neutrophils all up in your cavity, causing pain, edema, paralytic ileus. And so the signs you look for would be fever, hypotension, and also maybe shock. And you'll especially have shock if you don't treat this thing. So with that being said, we have a 68-year-old man. He's got diffuse abdominal pain, free intraperitoneal air, and thickened sigmoid colon consistent with perforated diverticulitis. There it is. Boom. There's the trigger we talked about. Autopsy shows a yellow tan strands of the liver capsule in the peritoneum. Which the following is most likely component? It's fibrin. So he's got this perforated bowel, and I'll move so you can see these explanations. Bacterial peritonitis. He's got the exudate, inflammatory stuff is happening, and it's fibrin that traps the bacteria. The fibrin's like, oh my gosh, guys, we're having a problem. Let's like trap this bacteria so that it can't spread. But if you have like fibrin on your tissues, then that's going to cause some problems. It's not type 4 collagen. That's the basement membrane stuff. It's not elastin. That'd be the stretchiness. Not laminin. Laminin is a big old carbohydrate group that's seen just on the extracellular surface of pretty much every single organism. And hyaluronic acid, that's good for retaining moisture. I don't know if you guys have ever used that. It's like kind of like a moisturizer. It's seen in like your eyes, like all over your body, keeps the moisture going. All right, for 61, anytime you see the word ischemia and they're talking about the renal tubules, then you should always think of the proximal convoluted tubule. And that's just always the case. And that's all I want you to know for 61. Super easy. I'm not going to harp on something if it's not important or could be stated very quickly and succinctly. Next, on that same vein, what do you do if you have a lot of kind of pale looking, weak looking red blood cells? Well, you just think immediately of iron deficiency anemia. Iron deficiency anemia can be caused by a lot of things like gastrointestinal blood loss. It's microcytic, hypochromic. Pale, you're just losing that iron, right? So it's just pale. They'll look like this, like they're kind of hollowed out a little bit. And I know you guys want a practice question, so I'm going to go ahead and give you one here. 76-year-old woman has exertional fatigue. Look at that anemia. MCV is low. Microcytic. What is the underlying cause? Bleed. It's a GI bleed. Microcytic, hypochromic, low ferritin, iron deficiency anemia every single time. You confirm this with colonoscopy. Bada bing, bada boom. Here are the reasons that it's not these things. B12 hypersegmented, autoimmune, spherocytes, myelodysplastic, would have pancytopenia. Bone marrow aplasia has low stuff. Liver tick, pancytopenia. All right, 63, I'm just going to remind you of the same question of like 61. Just PCT, ischemia. There are ischemic parts of the body that you need to worry about, but if it's in the kidneys, PCT every time. Next, we're going to go to 64. Here we have a 58-year-old male, chronic right flank pain, recurrent fevers, foul-smelling urine. He has a history of multiple urinary tract infections, large radiopaque stone, conforming to the shape of renal calyces, pH of 8.2, leukocyte esterase positive, and struvite crystals. What's the most likely causative organism? What's causing this? The big thing here is this pH. That's super basic, and the one that you should think of then is Proteus mirabilis. Also other Proteuses like Proteus vulgaris. But basically Proteus is a urease positive organism that increases the pH. You get the struvite stones. It's not E. coli. That'd be the most common UTI bug. Not mycoplasma that lacks the cell wall. It's not enterococcus. Doesn't produce urease. And not Klebsiella. It's less common in the stone formation. And really, if they're looking at something basic, then do Proteus mirabilis. All right, for the next one, we're going to distinguish between these two, slip capital femoral epiphysis and Osgood-Schlatters. Right? So what's the difference? Well, the age group can be similar, but the slipped is usually in growth spurt periods, and Osgood is for athletic kids. And that's pretty much all you need to know. Like that alone will help you distinguish Osgood-Schlatters because you'll be athletic in that one. And then typically the body type is obese. In a slip capitis, you have displacement of the femoral head, whereas this one's traction apophysitis. Basically, it's like the growing pains, but with the particular place that the muscle attaches, because these kids are strong, they're athletes. Okay, and that's the big difference. Here, we're just going to look at some clinical. If you see Osgood-Schlatter, sporty teen, below the knee. All right, in this next question, we have a 2-year-old boy brought to the pediatrician due to frequent respiratory infections, hepatosplenomegaly, developmental decay, and we see coarse facial features, corneal clouding, and we have a deficiency of alpha-L iduronidase. This is the giveaway here, and the corneal clouding. So it's Hurlers. It can't be Hunters because Hunters need their corneas to see. So it has to be Hurlers. It ain't icell. Why? Because that would be a mannose-6-phosphate thing. So it's not that. Gauche. Here's the explanation for those. Glucocerebrosidase deficiency is Gauche. You'd have hepatosplenomegaly and bone crisis. And Tay-Sachs, I pretend that this is an X and I say hex. Tay-Sachs hex. And that causes cherry red, no hepatosplenomegaly. That's the big deal. Easy peasy, lemon squeezy, right? Sure thing, bubba-ding. All right, next up, here we have a 24-year-old woman, comes to the ED with nausea, vomiting, abdominal pain, history of type 1, examination, she's tachypnic and dehydrated. Which of the following explains the initial evaluation and drop in the potassium? So yeah, her potassium concentration is going to drop. Anytime you see that, you should probably be thinking about insulin. And the answer is indeed potassium shifting out of the cells due to insulin deficiency. She has that acidic thing going on. It's DKA, hyperglycemia, ketosis, anion gap metabolic acidosis. Now, normally insulin deficiency prevents the potassium uptake, so you have too much potassium, and acidosis causes the hydronium ions to shift in the cells, and then the total potassium is low because of the loss through osmotic diuresis and vomiting. It's not B because aldosterone may increase, but it's not the driver, and diuresis contributes to body loss, not initial elevation, and poor intake can worsen hypokalemia. Insulin helps it shift in. Now, I also wanted to do some pituitary stuff and hypothalamus stuff. The hypothalamus stimulates FSH and LH. The anterior pituitary stimulates spermatogenesis in the males and follicular growth in the female. Anterior pituitary also makes LH, which stimulates the Leydig cells. And then the gonads themselves make the testosterone, estrogen, and progesterone. Now, the Sertoli cells, those secrete inhibin B, and that inhibits FSH. The granulosa in the female makes hormones. So, and that's like the granulosa in the female. Just wanted to go over some of those, and also some other commonly confused ones. FSH, there you get Sertoli cell activation and sperm production with inhibin B. LH, and that's testosterone synthesis. And the testosterone is actually a negative feedback instigator of the testosterone causes negative feedback and also male secondary sex characteristics. And inhibin inhibits FSH only. So the names kind of do what you think they do, which is fortunate. All right, next you have a 29-year-old man, 3-week history of painless bilateral inguinal lymphadenopathy and single painless ulcer, unprotected intercourse, multiple partners, Most appropriate therapy is what? So this is bacterial transpeptidase, but we need to know because of that painless genital ulcer, chancre, the painless bilateral lymphadenopathy is primary syphilis. That's caused by treponema. And the first line is always going to be penicillin because it binds to the bacterial transpeptidase and disrupts the cell wall integrity. It's not 30S. It's aminoglycosides. It's not first line for syphilis. It's not DNA-dependent RNA polymerase. It's rifampin stuff for TB. It's not dihydropteroate synthase. That's inhibited by sulfonamides. And it's not mycolic acid. That's the isoniazid for tuberculosis. It's penicillin. Cell wall synthesis inhibition through bacterial transpeptidase binding. All right. Next, we have a 6-year-old boy brought to the physician due to persistent abdominal mass during routine checkup, they noticed. He's got a smooth, firm, non-tender mass. In abdominal ultrasound, we have a 9-centimeter solid renal mass. Genetic analysis shows deletion of 11p13. Mutation in the gene encoding which protein? The answer is A. So this was a kiddo, so it was Wilms tumor, nephroblastoma. We had a large unilateral flank pain. Histology shows blastemal, the blue cell components. And it's the WT1 gene, which is the paired box, the PAX domain. WT1 is located right there on 11-13. You know that if you watched our chromosome video, you think of that as like the 11L, Wilms. All right, it's not polycystin. That's going to be autosomal dominant polycystic kidney disease. It's not type 4. That's Alport. Not epithelial sodium channel. That's in Little syndrome. And it's not urea transport. That affects the concentrating ability. This is Wilms. All right, and the last question here. 29-year-old man with HIV presents with the follow-up after recent change in his antiretroviral therapy regimen. Recent lab has significant decline in the viral load and increasing CD4 T cell count. Raltegravir is most likely to inhibit which of the following steps? Tegravir, integration. It's right in the name. The answer is C. So there are some steps to the HIV replication cycle that are worth knowing. First, you have to attach, right? That attachment, you have GP120 binding to CD4, and those would be your entry. That's your entry step, and so you block it with entry inhibitors like Maraviroc, or any of the CCR5 antagonists. And then we have fusion. And I love these because it's right in the name. Infuvritide, right? It's when you try to fuse with the host membrane. So you have to stop the fusion with the things that have few in their name. Fusion. And then there's the uncoding process. And another big one is any of the navirs. Those are protease inhibitors, right? And the protease inhibitors, they affect that protein processing phase. So with the HIV drugs, when in doubt, it's all in the name. Integravir, it helps with the integration, right? It's used in that step. Infuvritide, the fusion step, right? The navirs, you're never going to be able to protein process. That's how you remember them. All right, we just did 51 all the way to 70. If you found this helpful, like and subscribe. We'll see you guys in the next one. Hello, everybody. Welcome back. Today, we're on question 71. I've heard all of your feedback. The majority of you guys wanted no green screen, so you can see all the fun stuff going back in the room. We're on question 71. I've also been working on adding AI-generated images, which should go roughly with each question. The image will correspond to somebody who could have a similar condition, and I'll explain each one. So we have a 6-month-old boy evaluated for weight gain, current respiratory infection. All right, so you can see it just updated. On exam, he's tachypnic, mild subcostal retractions, cardiac auscultation reveals grade 4 to 6 holosystolic murmur at the lower, so it's that left sternal border and that holosystolic 4 to 6 sound, which really cue you into that diagnosis. Now, they could have asked this a different way, so here's a new question. Here we have a 6-month-old infant brought in for evaluation of poor feeding and frequent respiratory infections. Tachypnic, hepatomegaly, grade 4 to 6 holosystolic murmur at the left lower sternal border. And now they're saying which complication is most likely the condition if left untreated. So we established this is a VSD. So there's chronic increased blood flow through the pulmonary vasculature, and that's due to this left to right shunt. And so the answer is going to be pulmonary arterial hypertension. Okay, here's your explanation. Here's some other ones why they're wrong. Aortic dissection is not associated with congenital septal defects. Aortic valve. For that one, you should think of abnormal or previously damaged heart valves and dental procedures. That's subacute associations. So for this next question, there's a 19-year-old man with a known VSD, and on exam, he has a new holosystolic murmur, splinter hemorrhaging of his fingernails. He underwent dental cleaning. That is going to be Streptococcus viridans. It's the most common cause of subacute bacterial endocarditis on abnormal valves. Staph aureus causes acute endocarditis on normal valves. Enterococcus is seen in the elderly with GU procedures. Staph epidermidis is in prosthetic valves. And Pseudomonas would be rare, but in IV drug use, it would have rapid, severe valve destruction. All right, so the answer is going to be dopamine, where there's a really strong argument for serotonin as well, if you chose that. Now, it's not tyrosine, that's an amino acid precursor, which is not metabolized by an MAO, which, by the way, MAO inhibitors block the mitochondrial monoamine oxidase, and that degrades these things. So if you block it, then you have increased serotonin, norepinephrine, dopamine, and epinephrine. Or you could have serotonin syndrome and other problems like that. But this is seen in treatment-resistant depression. That's improved with phenelzine and transcyclopramine. tranylcypromine. So you're blocking the monoamine catabolism, and they mentioned aged cheese and red wine, along with severe headaches and hypertension, because tyramine escapes the first pass mechanism when MAO is inhibited. So tyramine-containing foods like aged meats, cheese, wine, soy, those are contraindicated. Also like tramadol, St. John's wort, linezolid, those can cause serotonin syndrome. And so this MAO normally is going to deaminate 5-HT, norepinephrine, and DA, epinephrine, but you inhibit it, and so you have increased vesicular stores. And it's not serotonin, though that could increase, since we're more dealing with our hypertensive crisis, not as much serotonin syndrome. You know, they could have said something like epinephrine as well, but that hypertensive crisis is less serotonin and more dopaminergic or epinephrine associated. Okay, so in this question, we have an 8-year-old girl. She's been tripping while walking, got double vision when looking to the left, so she can't look to the left. Her parents also have been dragging her right leg, so her right leg is dragging. And on exam, she's got impaired left eye abduction and broad-based unsteady gait, increased muscle tone on the right lower limb, with brisk reflexes. Which of the following is the diagnosis? Is pilocytic astrocytoma of the pons, slow-growing brain tumor astrocytoma. So she's got the left abducens nerve palsy, cerebral ataxia, right-sided upper motor neuron science, not Guillain-Barré, that's ascending paralysis, Gibbs ataxia, genetic and symmetric gait ataxia. Neuroblastoma would have lower motor neuron science, not the brainstem stuff, and cereballitis causes bilateral ataxia after a post-viral infection. Cool beans. So yeah, not the ascending, not bilateral problems. We see the brainstem problems, not spinal metastasis, because that would cause lower motor neuron problems, and acute cereballitis would be after some sort of an infection. And so our answer is A. And I think my microphone cut off on this one, so I'm going to redo it. A 22-year-old man will be shown up there. They have severe onset abdominal pain and vomiting for 3 hours. So there's our guy. He has no past medical history. Abdomen is distended. Contrast shows his duodenum does not cross the midline. So he's got a lot of his guts are just on the right side. And normally they're going to be spread without. So he's got some sort of intestinal malrotation, twisting of the bowel around the narrow mesenteric base. Jejunal atresia is common in neonates. Meekles, diverticulum, has bleeding and obstruction. Stenosis causes chronic partial obstruction. Hirschsprung's, failure to pass meconium. All right, so that's another practice question. My mic was off when I did it though. All right, for this next one, we're talking about phenylalanine elevation. So there's a 2-week-old male newborn found to have elevated serum phenylalanine. His parents follow a low phenylalanine formula strictly, but at 3 months, he develops tremors, fails to meet milestones. Which of the following best explains the symptoms? The answer is defective metabolism of tetrahydrobiopterin. So he's got hyperphenylalaninemia with a neurological dysfunction, even though he has dietary therapy. Phenylalanine transporter defect that would impair the absorption but not cause the elevated levels. Lack of tyrosine would not cause the neurological defects you see. Branch chain is seen in maple syrup, not PKU. Homogeneous oxidase deficiency is alkoptenuria that have the dark urine. All right, so there's your practice question. You can't metabolize phenylalanine. And this is inherited in an autosomal recessive fashion. And you would treat them by just giving BH4, because BH4 is the required cofactor for phenylalanine hydroxylase, also for tyrosine hydroxylase and tryptophan hydroxylase. It drives the synthesis of catecholamines and serotonin. So if it's deficient, then it'll cause increased in placidopamine and serotonin decrease. So you could have neuro findings despite a low phenylalanine diet. And you treat them with BH4, sapropterin, and also L-DOPA, carbidopa, and 5-hydroxytryptophan. But you should just look out for any positive newborn screens with high phenylalanine and worsening neurosymptoms on a low phenylalanine diet. Yep, there's the BH4 defect. All right, a study finds annual death rate from cardiovascular diseases of 4.8 out of 1,000 in diabetics and 2.1 out of 1,000 in non-diabetics. The attributable risk is just this minus that. 4.8 minus 2.1 is 2.7. All right, the attributable risk. This is super easy. You just do that minus that and you're good to go. So yep, the attributable risk. So RR is the relative risk and you just subtract them and you're good to go. It's super simple. All right, so now we're on 80. I'm going to keep working on optimizing the system so we can keep generating better images over here. But if you found this enjoyable or helpful, then like and subscribe. Hello everybody, welcome back to MBME 29. Today we are going to be starting off strong. Question 81. These videos take several hours to make, so please be sure to like and subscribe. Also, I've been listening to your feedback. There's no green screen today, just my wonderful back room, because that's what you guys decided on in the polls. And we'll start here with our practice question 81. A randomized controlled trial compares a new chemotherapeutic agent to standard care in patients with stage 3 colorectal cancer. After 3 years of follow-up, they report this data. The hazard ratio for recurrence in the new drug compared to the standard therapy is 0.72, and the confidence interval for 95% is between 0.48 and 1.16. So that 0.72 tells us that there is maybe some sort of a reduction recurrence. But this confidence interval means that it's not statistically significant. So the answer is C. There's no statistically significant difference in the recurrence between the groups. So the trick here is you have to determine if this contains 1 or not. And this one does contain 1, and so you can't tell if it's going to be positive or negative. All right, so this next one is commonly seen in elderly women, so I've changed that photo. And our practice question is, a 68-year-old retired librarian presents with persistent upper back pain after reaching to a cupboard. She has a history of rheumatoid arthritis and has been on prednisone for the past 4 years. Physical examination reveals kyphosis. That's like the hunching of the back. And point tenderness over the thoracic spine. Neuroexam is normal, and DEXA, that's like an osteoporosis thing, negative 2.9 at the femoral neck. We've got serum calcium, phosphate ALP, and PTH within normal limits. What is the most likely finding? Well, she had her glucocorticoid use, and we see fragility and kyphosis, and so there is a loss of the trabecular with preserved mineralization. So it's thinned out. So oftentimes the patient will present with some sort of a condition like polymyalgia rheumatica, for which they're using chronic prednisone. And glucocorticoids actually accelerates bone reabsorption, or you also might have a history of hypertension. Oftentimes in these patients, you'll have multiple vertebral compression fractures after they fall, and then they'll be like, hey, here's a biopsy, and then they'll give you questions about that biopsy, and you have normal mineralization. Whereas osteomalacia and rickets is defective mineralization, so you have a wide osteoid. You should also look out for osteopetrosis, that's increased mineralization. It's thick sclerotic bone, but it's also brittle. Brittle. That's petrosis. There's also Peutz-Jeghers disease of bone. And there you have thickened trabeculae and also mosaic lamellar bone with a high turnover rate. And then cortical thickening is definitely not osteoporosis. It's more like Peutz-Jeghers. So that thinned trabeculae, that is osteoporosis, especially if normal labs. Okay, so here's your explanation. So yeah, look out for that silent bone loss, glucocorticoid-induced osteoporosis. And the way to really think about this, to bring this home, is the bone has 2 major components. You have cortical bone, and you have trabecular bone. So the cortical bone is super compact, and that gives you your outer shell. The trabecular bone is really spongy, and it's the inner lattice work, especially inside the vertebrae and the hips. So trabeculae is the thin little struts that distribute the forces and give you the strength. And in osteoporosis, there's normal mineralization, but there's just like less bone. And so osteoclast activity is greater than osteoblast activity, and so there's net bone reabsorption. So both trabecular and cortical bone are thin, but their trabecular bone will go first because it has more surface area and a higher turnover. And that's why thinned trabeculae will show up on biopsy of osteoporosis, because the trabeculae are fewer and thinner, and the cortex is also going to be pretty thin too. But there's mineralization that's normal. So like the mineralization basically refers to the quality of the bone matrix. And there's no wide osteoid seams or defective calcifications, and so it's just osteoporosis. Because if there was defective mineralization, that's called osteomalacia. Basically, that's where the osteoid is laid down, but then it's not calcified, so you get soft bone in osteomalacia. If it were increased mineralization, then that's way too much mineral, and the bone would be super dense, but it's super brittle. Osteopetrosis. And then thickened cortex trabeculae, that's Peutz-Jeghers disease, and that's chaotic remodeling and thick but structurally unsound. This next one, we have a 29-year-old woman presented to the neuroclinic with complaints of persistent muscle weakness in her hands and trouble letting go of objects, so some muscle problems. Progressive thinning of her hair and difficulty climbing stairs. She had cataract surgery at age 25. On exam, percussion of the thenar eminence produces delayed relaxation. Her mother reportedly had mild difficulty with speech as well in her later years. So this is anticipation. So you're thinking, okay, trinucleotide repeat disorders, maybe myotonic dystrophy. Somebody in another chat mentioned, hey, do you have any videos on Huntington? Yes, we do. Trinucleotide repeat disorder video. Check that on the channel. But her younger brother also died of respiratory failure. So this is anticipation involving a repeat expansion of the non-encoding DNA. This is myotonic dystrophy type 1G. C stands for cataracts, T stands for toupee, and then the G stands for gonadal atrophy or infertility. And that's the triad in myotonic dystrophy that you should know, and that's how you link it up with cataracts, toupee, atrophy. Imprinting would be Angelman, Prader-Willi, chromosomal non-disjunction, is trisomy. The key to this one is just kind of recognizing what the condition is because of the cataracts, the toupee, the gonadal atrophy stuff. It could also be seen with myotonia. That's like delayed relaxation after contraction. So and a good example of this is you can't release a handshake. You can't relax. Also hatchet face deformity. So that's like a lack of facial expression. And arrhythmias, cardiomyopathies like cardiac conduction defects. Anticipation is the problem here. Sarcomeric point mutation would be hypertrophic cardiomyopathy. So yeah, watch for the grip myotonia, early cataracts, and cardiac complications. That's the CAG, CAG trinucleotide repeat expansion, autosomal dominant inheritance pattern. You see chorea, athetosis, that's like dance-like movements. And it also comes with cognition impairments like dementia, progressive cognitive decline, psychiatric stuff like depression, irritability, psychosis, and it's atrophy of the caudate nucleus, decreased acetylcholine, and decreased GABA is the way that I like to remember that, because CAG stands for caudate atrophy and decreased GABA, because the caudate nucleus is what's damaged. Whereas you contrast that with myotonic dystrophy, and that's, we discussed cataracts, toupee, gonadal problems. All right, now the reason we have this photo up here is because you also might see you got like a young mother and this mom is having some of the symptoms, or maybe throughout the family you see symptoms of myotonic dystrophy, and then it's going to ask about the little kiddo, and the little kiddo is already seeing those deformities, and so you know it's going to be anticipation. So those trinucleotide repeats are the problem. Hence my little photo there. Let me know in the comments where you would like me to be, if it's better if I hide the answer for a sec or something like that. I don't know. But the reason I have in this photo an elderly man is because you might be seeing this in somebody who's got some sort of a myocardial infarction. And this guy might have some sort of a respiratory problem. Let's say he's got like a bronchospasm. There's this thing that you need to be aware of called aspirin-exacerbated respiratory disease, and that is due to COX inhibition and the shunting of arachidonic acid to the leukotrienes. So you're not going to give this guy aspirin, are you? No, because he's got aspirin-exacerbated problems, and so you have to give him something else, like an antiplatelet. All right, so this is just one of the demographics you might see in this question, but now let's dive into our question of a 58-year-old woman who is admitted for unstable angina. She undergoes cardiac cath, revealing 90% occlusion of the LAD. A drug-eluting stent is placed. History includes adult-onset asthma and episodic wheezing. Aspirin's withheld. What is the mechanism of the drug that's added? All right, you probably heard of clopidogrel, the GREL drugs. Clopidogrel, the mechanism is it blocks the platelet ADP receptor, and you get decreased ADP-mediated activation of GP2B3A receptors. And those guys are going to cause decreased platelet aggregation. And I like to remember aggregation because it's 2 and 3, which are the bigger numbers, whereas adhesion with von Willebrand or Glanzmann is just the 1, which adhesion for some reason does not feel as numerous or as large as aggregation. So it's decreased aggregation due to clopidogrel's inhibition of the ADP receptor. Now, they might give you some trap answers, and we'll look at some of these, and I'll move myself out of the way now. Patients with aspirin intolerance are given ADP receptors to prevent aggregation. Thrombin inhibition would be the gatrans, not antiplatelets. Inhibiting cyclooxygenase 1, that's literally the mechanism of action of aspirin. So you can't do that. Don't worry, we won't give them aspirin. We'll give them cyclooxygenase 1 inhibitors. Same thing. Inhibits direct activation of factor 10A. Well, that's the 10A's in their name. I love that. They did that, by the way. XA, and anticoagulants, which are not your primary antiplatelets, and stimulating the prostacyclin analogs, so using pulmonary hypertension. They also might tell you other things, for instance, activating adenosine deaminase. Well, adenosine actually inhibits platelet activity, so that would be wrong. Doesn't have anything to do with serotonin either. Anything that inhibits gamma carboxylation is going to be warfarin, and warfarin is not an antiplatelet, it's an anticoagulant. And you might be saying, okay, well, what's the difference? Antiplatelet, anticoagulant. Well, antiplatelets obviously work on the platelets. Examples are aspirin through the COX-1,2 inhibition, which decreases TXA2. Clopidogrel, which literally blocks the ADP. MAB blocks GP2B3A. Dipridamol inhibits phosphodiesterase, increasing CAMP, and causes less platelet aggregation. Now, anticoagulation drugs actually work on that whole cascade, so they inhibit the clotting factors. And you use these for venous clots, DVTs, pulmonary embolisms, AFib. And examples are heparin, direct 10A inhibitors, direct thrombin inhibitors, warfarin, vitamin K-dependent gamma carboxylation of 2,7,9,10, proteins C and S. Don't you just love gamma? I think it's the third letter of the Greek alphabet. But yeah, so a big takeaway. Arterial events like the MI and stroke, you need antiplatelets, and then venous events, you need anticoagulant. And the reason why is these arterial clots, they form in high shear stress environments, the arteries. And so platelets dominate. They adhere to the ruptured atherosclerotic plaque. They're composed of platelet-rich stuff, and it looks white. So MI, stroke, antiplatelets. That's why you need aspirin, clopidogrel, that stuff. The venous stuff is the red clots, low flow, low shear, and coagulation cascade. You have a fibrin, mesh, and trapped red blood cells. So it's really all about that shear stress. All right, so post-MI and stroke, antiplatelets, DVT, pulmonary embolism, AFib, anticoagulants, gold beans. All right, for this question, we might see several different demographics, but here we have a middle-aged woman. And in our question, we have a 35-year-old man who's referred to by his employer due to concerns about his persistent isolation and disengagement at work. He lives alone, he has no friends or significant relationships, and says he prefers working the night shift because people are exhausting. This is clear. Schizoid. All right. Avoidance would be if he fears rejection. Odd beliefs and stuff is schizotypal. MD is not depressed and he's not narcissistic. So that's kind of an easy breakdown there. That's kind of all there is to it. I don't want to take more time to explain something if it's a simple piece of logic that gets you there. Some other things you might need to look out for is they prefer solitary activities. There's a lack of desire for close relationships and restricted emotional expression. Schizoid, you should think schizoid. Schizoid, the void of emotions, detached. All right, now I'm giving you guys another example of a demographic you might see on test day. For this condition, my goal is to help you think of a clinical scenario where, sure, in the question segment it says 67-year-old man, but you also might see a 65-year-old woman. And in this question, one of the key and most important factors is the smoking history. He's got a 45-pack year history, crackles, dullness, percussion in the right lower lung field. Chest CT shows 5.2 centimeters, centrally located mass in the right main bronchus. Okay, so there's some really important points here. And our answer is squamous cell, but another one that I want you to think about is small cell. Now, I put the explanation here on the screen for you to see. He's got pneumonia and hypercalcemia. Also, anytime that you take keratin pearls, it's squamous cell. The tumor secretes PTHrP, or parathyroid hormone-related protein, and that leads to hypercalcemia with a low PTH. So it's like doing the job of PTH, but it's like an imposter. That's squamous cell for you. Now, why is it not small cell? Well, what I wanted you guys to know is that small cell is also central. And that one would show neuroendocrine markers, not the keratin pearls. And you'd have rapid growth and early metastasis. So a good answer choice because it's central. Large is peripheral. And that's how I want you to think about it. Just be like large, peripheral, done. A carcinoid tumor would have very differentiated neuroendocrine cells and chromogranin A positive stained. Adenocarcinoma is peripheral. So guys, the easiest way to do this, I promise, is just think peripheral versus central. And how do you know it's central? Well, it has an S sound, central. Squamous cell, small cell, S sound, central. That's the way to think about it. It's the easiest way, I promise. Adenoperipheral, large peripheral, so you cross them out immediately. And then carcinoid tumor, neuroendocrine chromogranin is what should come to mind with carcinoid. But yeah, so speaking of other demographics you might find, it could be an elderly woman. She's a smoker, right? She's just been smoking her whole entire life. And maybe she's got some fever, some coughing, hemoptysis. But the finding is going to have to be a right or left middle lobe consolidation, a hilar mass. So like a central lesion. So squamous cell, small cell, and then adeno and bronchoalveolar carcinoma and large cell, that stuff, that's peripheral. But squamous and small is central and central. You need to know that. And then you have to know parathyroid hormone-like protein is related to squamous, whereas the small cell has all other sorts of goo associated with it. ACTH, SIADH, neuroendocrine goo. I cracked myself up. I don't know why. But yeah, adeno, what's there to say about adeno? It's the most common overall, especially in non-smokers. In fact, don't smoke, guys, because if you go to your doctor's office, they're going to be like, do you smoke? And if you don't smoke, you're probably not going to have squamous cell carcinoma, right? So you're saving yourself a whole form of cancer just by not smoking. So please don't do it to yourself. Unless you have ambitions to take over Europe or conquer Ukraine or some other territory, in which case, smoke all you want. I digress. I'm just trying to think like, what advice would I give to young Hitler? I'd probably be like, yeah, smoke all you want, man. Okay, I should probably just stop this train of thought right now. Anyways, adenocarcinoma is the most common lung cancer overall. Large cell carcinoma, undifferentiated, often peripheral. It's super aggressive. That's large cell. And like lymphomas, those can involve the hilar nodes, but you'd have like systemic B symptoms. Are you familiar with the B symptoms? Like night sweats, weight loss, lymphadenopathy, all that stuff. But smoking really makes the primary lung cancer diagnosis a lot more likely than like a lymphoma. So yeah, squamous cell, central lung cancer, strongly associated with smoking, can cause bronchial obstruction as well. And that could lead to things like post-obstructive pneumonia. But OMG, what's post-obstructive pneumonia? Well, that's an infection that develops in the lung tissue distal to the blocked airway. So it's usually a tumor, but it could be something else, a structure, foreign body. By the way, I have trained an AI model on everything you need to know for step 1 using widely available step 1 materials. And so all of these explanations are going to be deliberately curated so that they are high yield for you. And I'd be happy to go into that in another video, but the resources that you're seeing here, I'm not just saying airway obstruction for no reason or distal infection stuff. The only reason you're getting these associations, central lung cancers, squamous and small, because they are important and will be tested on step 1. I'll never tell you anything besides my random funny asides and memes that is not high yield for step 1. At least that's my goal. And please call me out on that and give me feedback. I love the feedback. All right, moving on. The big clue for the exam is pneumonia that keeps recurring in the same exact location. Over and over again, definitely think post-obstructive pneumonia. So you might see in the proximal right middle lobe bronchus. So you get that pooling in the post-obstructive pneumonia right there. All right, leaving the explanations on the screen for a second there for you. All right, question 86. We got a researcher. This is you. We're studying nerve regeneration in lab rats. Group A receives a crush injury to the sciatic nerve, and group B has the optic nerve. So already what's coming to mind? Sciatic, peripheral, optic, central. At the end of the study, histological examination reveals robust axonal regrowth and remyelination in group A. That's because it's peripheral, but no regeneration in B. What best explains this is the axonal regrowth is inhibited by the CNS glial-derived proteins. So the optic nerve is part of the central nervous system, and it's myelinated by what? Oligodendrocytes. And those guys release inhibitory molecules. You don't need to know those, but like NOGO, A, MAG, all that stuff. And they block axonal regeneration. Basically, some nerves regenerate and some can't. CNS axons will fail to regenerate every single time. You might say, oh, well, the optic chiasm is crossing, but who cares? The axons can't regenerate long before that. So it's not anything to do with neural crest cells either. The PNS, peripheral nervous system, neurons and ganglia are neural crest derived. But the optic nerve is CNS. It's from the diencephalon, the neural tube. So kind of different embryological origin there. And it's pretty much all there is for this one. CNS axons don't regenerate because they're myelinated by oligodendrocytes, which release inhibitory factors, unlike Schwann cells in the peripheral nervous system that can promote regrowth. And you guys might be wondering, okay, why though? From an evolutionary perspective, does it make sense to just always be able to regrow? For my undergrad at Harvard, I studied evolutionary biology and happen to know a little bit about this. Basically, evolution has decided stability should be prioritized over regrowth for the central nervous system. Think about the peripheral nervous system, right? You need to regrow it. You get your limb chopped off. Ouch. You get it crushed, right? A crush injury. We have to regain the movement of our periphery, right? So the Schwann cells go to the rescue. But the CNS, there you have tons of billions of connected neurons. And if you regrow them, all of a sudden my eyeball is connected to my elbow. Not good. You could even get hallucinations, seizures, all that stuff. And so yes, if there were some divine technician that could come down and rewire you, then yes, it's a great idea to regrow them. But in an evolutionary landscape that's prone to mistakes, miswiring, aberrant circuits, and wasted energy on inaccurate repair can all take place. And so Azathoth, or whoever made you, random chance by natural selection, has decided it's in your best interest not even to mess with that. So that's the evolutionary mechanism behind CNS and PNS design trade-offs. Cool beans? Okay, there's the explanation for you. All right, and it's all about the myelination patterns, right? Myelination patterns, the inhibitory proteins of the CNS. You learn something new every day. Kind of fun, kind of quirky, kind of cool. All right, the demographic that you might see in the next question could be man, woman, elderly. Basically what USMLE was trying to do for this topic, at least, is they're trying to say, hey, how could we get somebody in a demographic for colon cancer? And so that's why I've given you this woman up here who meets that criteria maybe. So in our question that I've made myself, we have a 66-year-old man presenting with progressive fatigue, vague abdominal discomfort, decreased appetite over the last 4 months, dark stools, unintentional weight loss, so cancer. Oh, wow. 50-year smoker and alcohol consumption. Hemoglobin is 8, hematocrit 26. Look at that mean corpuscular volume. Normal AST, ALT, ALP. Platelet count is crazy high. Which organ is most likely involved in the metastatic spread? Okay, so the answer is the liver, and let's talk about why. Our labs show us colonic adenocarcinoma, and colon cancer most often metastasizes first to the liver. And how does it do that? Well, there's this awesome thing called the portal venous system, and GI blood will drain, and you'll go from the superior inferior mesenteric veins to the portal vein to the liver. And so the colon cancer can metastasize and the liver will get that metastasis. So the liver metastasis is more common than primary liver tumors. Like for instance, hepatocellular carcinoma. It's even more common than that, right? Now, why is it not the brain? That's the site for lung melanoma and renal metastasis. Why not the lungs? That's common for sarcomas and renal, but colorectal drains from the liver. Skin metastasis is rare, seen in melanoma and breast. And then the bone, typical prostate, breast, and lung. So basically, the hard part about this question is the liver is the most common site for metastasis of the GI cancers. And the reason why, I'll explain here. So blood from the colon and the rectum drains into the SMV, drains the right colon, the IMV drains the left, and they both join the portal vein to the liver. So basically all these tumor cells are going to be shedding in the venous blood and going straight to the liver. It's the first pass filter. The liver obviously has a huge blood supply, 25% of your cardiac output, and it's got some leaky stuff to it, the fenestrated sinusoids. And you've got some growth factors there, and so it's really good for tumor growth. Now, lung cancer spreads to the brain, adrenal, and bone, right? Because there we have systemic venous return to the rest of the systemic circulation. Prostate and breast, there you have bone metastasis that's common, just because the microenvironment there is really nice for it. And melanoma can spread everywhere. Skin, brain, liver, lung. But how do you know that granny has cancer? Well, I told you about the age, right? So we had cancer risk at that age anyways. And then there's constitutional symptoms, right? We get the weight loss. There's also GI symptoms, the chronic constipation, maybe you'll see. And you could even inspect it and they'll show like some sort of a mass and it'll be like a firm rectal mass. But also look at that MCV, right? Also look at this MCV. Now, in elderly adults, this is iron deficiency anemia until it's proven otherwise. So in this setting, the occult blood loss is from a colorectal tumor, right? That's the number one cause. And if it were gynecological in nature, then you wouldn't find the rectal wall tumor either. If it's hematologic, think a lymphoma, for instance, then the mass would not localize so clearly to the rectum, and the labs would be a little bit different too. So you see rectal colonic mass, iron deficiency anemia, and weight loss, that's colonic, you know? And then you think the number one metastasis site is the liver. So that's the answer. All right. Look, I found a picture of you on the web. A research team is developing novel vaccine against Haemophilus influenza type B using capsular polysaccharides to enhance immunogenicity. They're testing several conjugation strategies in mice. One formulation combines polysaccharides with bacterial protein recognized by toll-like receptor 5. What's the outcome of this approach? Well, the answer is increased switching to IgG via T-dependent activation. Now, the problem here is that polysaccharides like Neisseria meningitidis, or rather the capsule that they possess, by themselves will have T cell independent antigens. So they activate the B cells directly. But the response is mostly IgM, right? And that's short-lived, there's no memory of it. So to get IgG class switching in memory, you need T cell help. So how do we get those T cells in there? Well, we're going to conjugate the polysaccharide to a protein carrier. And the question is, which protein carrier are we going to use? Well, we want something that's strong, immunogenic. We want something that activates antigen-presenting cells, and something that stimulates T helper cells, because that will promote B cell class switching to get that stronger response. And so we conjugate it to flagellin. Toll-like receptor 5 ligand provides T cell dependent antigen presentation and innate immune stimulation. It promotes the class switching, memory B cell formation, and higher titers. It's perfect. Enhanced IgA is mucosal. IgA is good for that, but we're targeting the IgG. Cytotoxic T lymphocytes, cytotoxic 8, think MHC1. So polysaccharides don't enter the cytosolic pathway needed for CD8 positive T cell activation. And immune tolerance, repeat exposure without co-stimulation. That's when you should think of tolerance. And antibodies without T cell involvement. Why would you need that? That's what we're trying to solve. So it would be E. And so basically these pure polysaccharide vaccines, like those that are used against meningococcus, they don't work very well in infants. And that's because they only trigger a very weak IgM response with no memory. But if you add a flagellin, then the whole thing will be treated like it's a protein antigen. And now if it's a protein antigen, the B cells can be like, oh my gosh, let me show this to my MHC2 buddies. And then the T helper cells are going to be like, oh my gosh, let's do a helper response. Oh my gosh, let's make Ig. And that's how we get that reaction. And toll-like receptor 5, that's just icing on the cake. It's not going to be other stuff like dinotrophenol. That's a toxic mitochondrial uncoupler. You wouldn't just use like a sugar, because sugars will just stabilize things. And lipopolysaccharides are immunogenic, but they're too toxic, and sometimes they can share epitopes with host cells. So you would not necessarily want to use a lipopolysaccharide. Palmitic acid is just like a common, lactic acid or fatty acid. Those aren't immunogenic. So just look out for something immunogenic, something that would help with this situation with the TLR5 ligand, causing the T cell dependent reaction, and flagellin's perfect for that. You get class switching, memory formation, and all that good stuff. Now, this next demographic is probably going to be elderly. It could be a man or a woman, for instance, like what we see up here, who just falls. They could have an enterotrochanter fracture, something like that. And the problem is they've got their like a shortened externally rotated leg, or some sort of a hip fracture. And there's a mnemonic that's super helpful for this. P-go-go-Q. P stands for piriformis. G is the gemellus superior. O stands for obturator. G is another one of the gemelluses. I think it's like gemellus inferior. O is also the obturator, but this one's the externus and this one's the internus. So it's the obturator, gemellus, obturator. So G-O-G-O. Q is quadratus femoris. Okay, so P, go, Q. That's the mnemonic. And those are the lateral rotator groups, and they all insert around the greater trochanter, and they're the prime movers for lateral rotation. So here we have a 68-year-old man, difficulty walking, left hip pain after slipping while getting out of the bathtub. His left leg is shortened, so lies externally rotated compared to the right. What contributes to the external rotation of the thigh and may be impaired? Obturator externus would be on that list of P-go-Q. And that's all there is to it. Gluteus medius is abduction, because usually people say maximus, and it's abnormal if you say medius. That's how I remember it. Sartorius, Taylor's muscle, hip flexion and knee flexion. Vastus lateralis, knee extension. Adductor longus, well, adduction. So yep, fractured hip, it'll rotate your entire leg out like it's a broken hinge. All right, next our demographic is going to be some young boy or young girl. In this case, we have a young girl who's brought to the clinic after collapsing during a school choir rehearsal. She has no prior medical history, but has required hearing aids since infancy. On exam, she's alerted with normal vitals. Her ECG shows a QT interval of 520. Genetic testing reveals mutation in a gene involved in cardiac repolarization, which the following best describes the mutated protein. All right, this is Dravet Lange-Nielsen syndrome. It's congenital long QT syndrome caused by mutations of the voltage-gated potassium channel. So here's our explanation, and you might be wondering, why is it potassium? Well, normal cardiac repolarization has outward potassium currents, and if the potassium channel function is defective, then it's delayed repolarization, and delayed repolarization has a longer QT interval. And so the prolongation predisposes torsade de pointe, syncope, or sudden death. And what's with the deafness, right? The inner ear cells also rely on potassium channels. That's what's interesting about this condition. And they recycle the potassium to the endolymph, which is, just like the fluid in the membranous labyrinth of the ear. And there's dysfunction there, right? So you have congenital sensory neural hearing loss. And this is autosomal recessive, where you have the cardiac problems and you also have the ear problems. There's also another variant of this that's called Romano-Ward, which is autosomal dominant, and that's only involving the cardiac. There's no hearing loss with that one. And they're going to try to get you with all sorts of answers for this one. They could ask about neurotransmitter calcium, for instance. And that can be implicated in epilepsies and some arrhythmias, but definitely not long QT syndrome. They could try to get you talking about cholinergic receptors. That would be the parasympathetic slowing of the heart rate. And that's just not related to QT stuff. They'll get you about gap junctions, and that's involved in propagation, not repolarization. And it's not beta adrenergic, because that could exacerbate it, but the receptor is not mutated. All right, so there you go. Hopefully this has been helpful. These are 10 more questions. If it was, like and subscribe. Let me know how I can improve. Do you guys like this demographic image for each question? Would you like for it to pertain exactly to this question, or just general demographics so that I can generalize these questions better and open up the conversation that way? Let me know what you think, and we'll see you guys in the next video.